Welcome to your RCPCH Patient Safety Podcast, where we delve into the successes and the challenges of creating a healthcare environment that is safe for children and young people.
I'm Jonathan Bamber, Head of Quality Improvements at the RCPCH.
And I'm Natalie Wyatt, a Quality Improvement Fellow with the RCPCH.
In this episode, we're going to discuss the creation of a culture of safety and how that can keep young people safe. To explore this further, we're pleased to be joined by Dr Peter Lachman. Peter is a consultant paediatrician and patient safety expert. He's currently working at the Royal College of Physicians in Ireland to develop clinical leaders in quality improvement, and has previously led patient safety improvement work in a number of roles, including the CEO of ISQA, which is the International Society for Quality in Healthcare, and as the editor of the Oxford Professional Practice Handbook of Patient Safety. So welcome, Peter. Thank you so much for joining us today.
Thanks for inviting me. It's great to be here.
To get us started, Peter, we've shared a little bit about what you've done, but could you tell us a little bit more about yourself and how you became interested in paediatric patient safety?
Well, I'm a paediatrician by training. I trained in South Africa, and my very first case, which I didn't realize when I was a registrar, was when a house officer inadvertently gave a baby a potassium chloride and the baby died, which is a human factors error. This was many years ago. But that poor doctor and the nurse who was in the process both lost their jobs and were charged with manslaughter. And it was basically a production line safety because it was in Cape Town. We had a very, very lean system of babies coming in to the hospital having diarrheal disease. And they had to decide whether they were acidotic or not on entry. And he asked for 5 mils of soda bic, but got 5 mils of potassium chloride in error. And the vials were exactly the same, except one had red writing, one had black writing. They were glass vials, and they were kept side by side. So it is a pure design human factors problem, but that was in 1984, before we knew about human factors in healthcare, before we knew about patient safety. And I didn't know that situation where I had to tell the parents that we had actually killed their baby. I didn't say it that way, but I had to say that to the parents that the baby died through a medical error. We did not at that stage know anything about patient safety, but I didn't realize that that was the first incident and which would set my career in patient safety when I was a young registrar in the first or second week of being a registrar. So if you want to know how I got in it, that's the first of many stories I can tell you. And that was in a very high-performing unit, in a high-performing hospital. It was award-winning treatment of diarrhea, many papers written about how we did it, but there was a fatal human factors flaw in the design, but no one was speaking about human factors in those days. And I hate to say it, that over the last 40 years since that event, because it was around about 40 years ago, nothing much has changed in terms of human factors, is that you still have medications sitting side by side that nurses or doctors incorrectly give to patients because the design is not correct.
That's incredible, isn't it, to think of that over a 40-year span, and you still can reflect on that same problem there from when you back at your first days as a registrar.
Yeah, I could tell I've got others. I always think that as I went through my career, I was very fortunate to escape, but I was involved in many, many incidents as the person sorting it out. But most young doctors today, your trainees, the doctors in postgraduate medical education, who we call junior doctors, who are not really junior, most of them have similar experience, and they will be able to tell you that they've had that kind of experience, or they know someone who's had that kind of experience, or they've had a very big near miss with that kind of experience I've just described. So it's a lot to do to make it safe.
Absolutely. And one of the things that we were kind of hoping to focus on today is thinking about how a culture of an organisation might make it more safe. And just to kind of set the scene for people listening today, if this is something new to them, could you tell us a little bit about what the basic principles are of a culture of patient safety? What does that mean to you?
Well, I regret to say I don't think that healthcare has really developed a culture of patient safety, because if it had, it wouldn't be designed the way it is. A culture of safety is, firstly, you have to think differently. It's about a mindset. It's about the way you think about the work you do. It's what you think about every day when you come into work. It's about recognition that healthcare is incredibly dangerous, and that because it's so dangerous, we have to make safety a priority in all our actions. And we have to ask about safety all the time. We have to think safety. So it's a mind thing. It's not about policies. It's not about slogans that all the NHS trusts around the country have, caring, safe, friendly, you can name it. You go to everything, respect. I can give you the list of verbs that they throw out there, which they think means that they have a culture of safety and quality. And it's all nonsense, because the executive teams, the clinical teams are not thinking safety every minute of the day. And that's the difference. That's what cultural safety is that you think about safety every day. And that's had to happen in other industries before they became safe. But healthcare just mouths it. And I get very despondent when I see leaders talk about culture of safety, and yet they make young doctors work incredible hours in situations which they cannot be safe. So action is self-thought to action. That's what culture of safety is, where this thinking about safety becomes action about safety every minute of the day, not only when there's an incident.
What are the essential components of designing then a healthcare setting? Say you were starting from scratch. We haven't got this healthcare setting that we have. If you were starting from the beginning, how would you start designing a system that kept safety as part of everybody's everyday thought and that converted it into action?
Well, I think that we've got a problem here, is that the system has been designed. So what we are trying to do is change a system while we're flying the system. So I'll just take a paediatric unit, or I could take the work we did at Great Ormond Street, because when I was there, we really tried hard to engender a culture of safety and put safety on the agenda. And we had, fortunately, we had a chief executive who started safety walk rounds and started going out to the front line to find out what bothered them, what was really the issues that made them feel unsafe. So if I really wanted to redesign a system, I can't stop a system. That's the problem in the healthcare. We can't stop a system and say, we're going to stop, we're going to redesign it, and then we're going to come out with a new system. I mean, I'd love to do that. But what I would really start looking at is I'll look at a long-term program of redesign. The first thing is equipping the workforce from day one. And day one starts on day one of medical school. So just as we have training in physiology and pathology and anatomy as core parts of your training in medical school, and you can't graduate without knowing pathology, physiology, and anatomy, so I would put all the elements of patient safety as part of that core. So just when you are learning about the physiology of something, you must learn about the risks and the safety issues that you might have to address for that. So if we look at, for example, when you're learning about neonatology, and you're learning about, let's say, HIE, or you're learning about retinopathy, or you're learning about respiratory diseases. So you must be learning about safety issues that babies in a neonatal intensive care will face. And they're numerous. I could list, but we don't teach that in neonatology in medical school. And we don't teach it in neonatology when they are doing their registrar training. We don't have every day the neonatologist saying, let's discuss the safety issues that we have for this baby. They discuss how we treat the baby, but not the safety issues that we have to do to prevent the baby having a line infection, for example.
And would you say that that's, if you were going to introduce patient safety as part of this long-term strategy within medical training, how you align or fit that into the focus on clinical outcomes as if that's something different? Would you change that language and that what is success is a safe environment? And I would have thought that within medical training, there's what is the clinical outcome we would have, and wanting to separate out patient safety? It would be a question of just reframing what our definition of a good outcome is.
It is, but that's now we're getting back to what I started with, what you think. So a good outcome is not a live baby, a live graduate from the intensive care. I'm just using intensive care as an example, because that's the highest risk area in pediatrics, is the intensive cares. I'd say the good outcome is a live baby without any unplanned extubation, line infections, pressure injuries, etc., etc. Can you see? And I could list I could say, where's a neonatal unit that measures the success in the absence of harm?
Yeah.
Can you see? They don't do that. They don't do that.
And where would the motivation come to change that thinking?
Well, actually, this is where the college steps in. So part of my history is that I've been working with the college for the last 15 or 16 years since I came back from IHI. And when I came back, and the difference between the college now and then is very big, because patient safety wasn't seen as an issue in 2005. Mm-hmm. In 2005, it was early days. Okay, it was the very start of the thing. But now patient safety is on the agenda.
No.
But is it on the agenda in the fact that as part of the training, every resident or every registrar has to be proficient in human factors before they can graduate? I know they have to be proficient in neonatology and in general pediatrics and a bit of community pediatrics, but human factors, I don't see that there. So if you really want to have it changed, the college needs to say, these are the things that are going to be important to graduate, and you have to know about patient safety in a certain amount of detail as a new graduate pediatrician. And that is important. And while they're doing that, the medical school should be doing likewise to graduate as a medical student. So that when you get someone coming in from medical school into ST1, and then from ST1 into registrar ST4, they're going on a journey of learning about patient safety in greater and greater detail, so that when they become the consultant, they are able to implement the changes that we want in terms of patient safety because they're proficient. Unfortunately, the vast majority of our consultant leaders in the country have got no knowledge about the theories of patient safety. It's not their fault. It's just that they were never taught it. They never had the opportunities. It's seen as a niche market. And that's the problem with patient safety. It's still exotic, something someone else does. And it is because originally patient safety was seen as a reaction. How do we manage adverse events? It was seen as a defensive action by organizations. How do we manage risk? Not risk to the patients, but risk to the organization. And so we've got to turn it on its head. We've got to think totally, totally differently. And think what's about safety is how do we keep babies and young children the highest risk of patient safety. So the most safety events are in the under 5s and the over 70s. So that's where your risk is. In between, you do have it, but it's not as high risk in those areas. So how do we ensure that pediatricians who deal with the highest risk, and obstetricians, because also in obstetrics, that's very high risk, how do we ensure that they understand human factors, they understand resilience engineering, and learn from what works well? How do we get them to do that? That requires a culture of safety. And the culture of safety starts in education. It starts at the college. It starts at the medical schools, the nursing colleges. That's where we're educating the people for the future. That's what the culture of safety is about. When we start to think differently, so we have to educate differently. Then we get to the actions in the hospitals or in the clinics. We start talking about it every day. We talk about incidents. We don't report it to the clinical incident team who then does a root cause analysis. You get a result 6 months later. What a waste of time. The clinical teams should be talking about safety every minute of the day.
And that was one of the great collaboratives that you were involved in setting up, Peter, wasn't it?
Yes.
The SAFE Collaborative, which part of that focus was about having those conversations every day that everyone was involved in. Do you want to tell us a little bit more about that programme of work?
Yeah, well, that program work is probably, it's one of the proudest things I've done because it was empowering of people. I was very lucky. When I came back from IHI, I was offered a position at Great Ormond Street, which was a great laboratory to implement change. So that's what we were able to do a lot. And I was given funding, so it's support team, and very importantly, an executive team that supported me. So chief executive and board. The board supported chief executive, and patient safety was high on the agenda. And we came at Great Ormond Street with zero harm, no waste, no waste. Way before everyone's talking about zero harm, we were talking about zero harm in 2006. And that's where I was able to test out these ideas. And I linked up with Cincinnati Children's, who was the leaders in the United States, and visited there a lot. Our executive teams visited. So both teams went both ways to learn from each other. And we really pioneered a lot of things in patient safety. So all my credit to my time at Great Ormond Street. And at the same time at the Royal Free, where I was clinically based, I had Sebastian Ewan as a fellow. Sebastian and I did the first, and Nikki Davey, we came up with, and I worked for the International NHS Institute. We came up with the first pews, which got lost because of a change in government when the institute closed. So we did the first pews in those days. And I was very fortunate to have a fellow in patient safety working on this. And at that time, Cincinnati came up with the idea that if you did huddles, talked about safety every day, just like they do in other industries, things would be safe. And they published a few papers. I ended up writing an editorial in BMJ Quality and Safety on it, and I applied for funding from the Health Foundation with the college as the lead to do in closing the gap for patient safety. An idea that we could apply the Charles Vincent model of measuring quality to an everyday practice. Charles had come to us at Great Ormond Street and studied us, and we were one of 5 or 6 organizations studied to come up with that model. And so it was really about getting clinical teams to talk about safety every day. And then I took that and applied it to clinical teams, and I'm still doing it now. And we got funding from the Health Foundation and Well Child, a 2-year program. I then used my connections, 6 children's hospitals, 6 DGHs, to study in a collaborative, to study how we're going to do it. It was a 2-year program, 2-year funding. After the first year, not even after the first year, after the first 8 months, we presented our findings at the college at the meeting. I think it was in Birmingham, and was standing remotely, and people all clamored, we want to do this. So we asked the Health Foundation if we could extend it. It was the same money. We didn't ask for more money. We said, can we extend it? And we extended it from 12 initial hospitals to another 16. We ran 2 more collaboratives. And when it was finished, we asked the Health Foundation, could we extend it even further? And what was happening was the first 2 years was finding out how to do it. And then I went from a 2-year implementation to what we do now is a 6-month implementation. And I'm doing that in Ireland now. Have done 50 teams. I've got another 11. People are clamoring to find out how can we be safe. And what we teach clinical teams in this is at the start of every day, the end of every day, in the middle of the night. So we normally say about 3 times a day, but we ask you to ask 6 questions. And those questions will help you apply theory into practice. So we don't teach them human factors. We treat them applied human factors, applied resilience theory, applied. So I say this is what it's called by the safety people, but now you're going to translate it into action. And so the clinical teams at the start of a session will say, what have we done really well? So we're now building the culture of safety on pride. And we didn't have any line infections. We didn't have anyone falling. We got everyone home on time. All these kind of things that people don't normally talk about, that builds resilience. And that's building resilience, which is so important for the second question, is in the last shift, did we harm anyone? And what we get clinical teams is we say, define your harms with the parents and with the staff. So if I'm in a neonatal ward, I know what the harms are: line infections, extubation, pressure ulcers, retinopathy, you name the 5 or 6 that you get, and you're going to measure those. And that's what we're going to ask everywhere. Did anyone have unplanned extubation? Did anyone have a line infection? Did anyone, etc., etc.? And so they're talking about it every day at the start of the day. And at the end of the day, they say the same thing. Did anyone have it? So now they're talking about safety, but they've already got resilience because they've already said what we've done well. So people are able to talk about it in a non-blame area. And if they've got that, they're going to say, okay, what are we going to do about it? After this huddle, they'll do a quick root cause analysis with the 5 whys. What do we have to change? What do we have to fix? And I was once in Sydney doing this, and the house officer said we undertreated a baby with meningitis for 4 days because they sent in estimated weight and we didn't weigh the baby because the baby was too sick. And when the baby was rehydrated, we realized that we were under-treating the baby for 4 days. And that estimated weight was on the new electronic record. And they immediately referred it to, they didn't wait for a root cause analysis. They changed the system in the ED about estimated weights. So they changed it immediately from that one house officer saying, this is what we did wrong. And then the next question will be, are we reliable? Are we doing what we're supposed to do? So now you're bringing in reliability theory in. So people are talking about, are we following the guidelines? And I don't care what guideline, but are we doing it reliably? Not what each consultant wants to do, but what the consultants have agreed to do. And if not, do we have to change the guideline? Or why did we not follow it? And the next question is the human factors one. Are we safe right now? So then we bring in the SEEPS model, that's human factors. So I say, this is the SEEPS model, and that's the last time I'm going to call it SEEPS, but I'm going to teach you how to apply it. You're going to ask, do we have the right patients? Is there an outlier who shouldn't be here because that's unsafe? Do we have the right people? Like we've got a new nurse, doesn't know how to use the pump. Okay, what are we going to do about it? Okay, we're in handover, we've got new doctors, they don't know the system. How are we going to support them? So that's the right people, the right equipment. Do we have everything we need? Do we have the right tools? Can everyone do the tasks? That's quite interesting because often people can't do tasks. So if they can't, so we start talking about it. And often young doctors don't want to admit they can't do something because they feel that they'll be judged. But now it's an open discussion. And then finally, how are we organized? Are we feeling good today? And one of the things there is, for example, someone can say, well, a young doctor just back from maternity leave can say, well, I didn't sleep last night. Could someone help me? Because today I may make an error. So now we bring in the psychological safety. Can you see? So we bring it into the front line. And then the next question is, are we going to be safe in the future? So this is where we get situation awareness. And what the nurse and doctor have to do, the resident or a registrar or the house officer, what they have to do is say then, this is the situation. These are the patients we are worried about. The nurse will say and the doctor is, and anyone can raise it. We used to get the school teacher coming into these meetings, the dinner lady coming into these meetings saying, this child didn't eat it like today, didn't choose to eat the food today. Something's going on. Can you see? So we're getting everyone through. So this is situation awareness. And then the last one is what have we learned? And a quick after action review. So can you see what's happening there? In that 15 minutes only, it takes 15 minutes, twice a day, people are talking about safety in a safe environment where they feel psychologically safe, they're not going to be judged, and they're making actions. And all of these, at the start of the program, we measure their MAPSAP. And then over the course of the 6 months, we measure their MAPSAP changing. And what happens is that communication improves. The nurses start saying, we now know what the doctors are thinking. The trainee doctors say, we now got consultants who are doing the same thing. So people are starting to talk about safety. And what happens on the MAPSAP, the indices improve over a 6-month period. So the culture of safety is being engendered by people talking about safety every day in a safe environment. So I think that SAFE program, we call it the SAFE program, situation awareness for everyone, provides psychological safety, it provides teamwork, it improves communication, it decreases incidents, or it may increase incidents because people are talking about them. They start talking about near misses. Doctors and nurses feel safe. And people who come into units that have done it, they say it feels differently. So I asked medical students, what's it like in the units? And they say that unit feels differently. So will they be on the program? Because they're now talking about safety all the time.
Absolutely. And do you have to do much of an extra piece around flattening hierarchies and things like that in implementing the program? Because obviously, as you said, it sounds like you need to have an environment that everybody feels very safe to participate in. And our structure of healthcare is very hierarchical, and that is a challenge.
So when I start the courses, like we start next one, there have to be 4 members of a team. So there's a consultant, has to be there. And that consultant could be, depends, it could be a physio team, an OT team, could be the most senior person. But usually in a ward person, we want a nurse leader, a doctor leader, and 2 people on the ground. Okay, so that's the registrar, house officer. Sometimes they can bring a parent if they want to, whatever. But the key thing is we talk about hierarchies. And we say that it's always important to be a hierarchy because someone has to make a decision. And the thing about flat in hierarchies is a misnomer. It's about having a hierarchy according to the role at the time. So when I learned this from Cincinnati, because they went to study the US Navy, and they went to the ships, and they said, when a pilot, a Top Gun, Tom Cruise Maverick,
Tom Cruise is there. Yeah.
When Tom Cruise is landing on the plane, he is not in control. It's actually an ensign who's standing on the deck with this gauge that's looking at the degrees that he's coming in, and saying you need to flatten, you need to do it, because otherwise he'll overshoot or otherwise he'll hit the plane. So even though he's the Top Gun, the most important person is the person telling what angle of degree his plane is when he comes in.
Yeah.
But when he lands, that person will salute. Yes, sir. No, sir. Can see it. Then the hierarchy is back. But the role hierarchy. So, for example, the person with the most knowledge about the child is the mother. So the mother's view should trump everyone's view. But in terms of hierarchy, the mother's at the bottom of the pile. Can you see? The junior doctor, the doctor in the front line, or the medical student may have the knowledge that the senior doctor doesn't have. So in the huddle situation, we teach them that at that point, you have that flat hierarchy. But when the decisions are made, someone has to take a decision and make a lead with all the information in, but be willing to be challenged for that decision. And if someone is challenged for the decision, then there needs to be a review. So it's a flexible hierarchy. It's not a flat hierarchy. It's flat for the time, but it's got to be flexible because someone has to make decisions.
So it's a really interesting example around the ensign on the deck when Tom Cruise is landing.
Yeah.
Often in health situations, there's not as much clarity of how those roles should flex, in that the control should be moving away from the person who has that traditional hierarchy. Because don't we have problems when it's the consultant or the equivalent is always sort of their view is being taken as gold dust, even if they haven't got all the information.
Yeah.
So how do we instill an environment where those roles are appropriate and can flex in the situation?
First thing is, and I go back to what I said, we've got to prepare the consultants of the future, so that's the way they think. So on that sense, I run a course here in Ireland called Essential Skills for New Consultants. That's what it's called. And we teach them that for these new consultants. I don't do it for pediatricians only. I do it for a wide range of consultants. And I'm just reading their feedback right now for the last course because they do a final reflection. And their eyes have been opened because they're starting to think about, we teach them reflective practice. So like you taught reflective practice as a trainee, we teach them to do it as a consultant, which is slightly different as when you're doing it as a trainee. Because now you're reflecting, how do I interact with the team I'm working with? Can you see it's a different way? Did I engender psychological safety? Did I do this? So we teach them a different type of reflective practice. The same principles. We teach them what now, what, so what. You know that model, the Rolf model, or the Gibbs cycle. We say we can use whichever one we do, but we teach them that, and they learn about reflective practice. I go through the reflections, so I see them grow. So we're teaching young consultants how to be good consultants. Then, of course, unfortunately, we've got the consultants in post. So that is more difficult because we have to sort them out. And that is, we have to help them see the new way of teaching. And that is where leadership comes in. So how I would go there is ensure that in the 400 organizations around the country, we are looking at leaders who will be able to be clinical leaders in their areas and being role models and examples for the other consultants. That's where the college comes in. So that's looking at the two ends, because we've got to do the two ends. At the same time, what we're doing is including all of this in the training for young trainees at the bottom who are training through. And I really think that in an organization that provides cultural safety and value and a sense of belonging, then you'll find the trainees are not going to only feel that they've been undervalued in terms of money, but they're also now feeling they're undervalued in terms of respect and well-being. So what we have to do is most people enter into public service not for the money. They know that they could earn more money in private practice. They earn it for the common good. Part of the common good is feeling safe. And if you make sure that the young doctors and nurses and allied professionals are all feeling safe, that we value their opinion, that we're creating this culture around them, that requires the leadership to do it. So can you see the different strands? It's very complex, but it is possible to do. And all I can say is that when you're talking to other people on the podcast, they are a lot of the people who've come through the programs I run. so I can see, when I look back, I can say, oh, that's great that you've had people who've been my Darcy Fellows or worked with Darcy Fellows with me or had been on programs I've run or written papers with me are now patient safety leaders. Well, that shows me it can be done.
I wanted to go back a little bit onto the way you were illustrating what is gone through on each of the safety huddles and if you're following the SAFE program. And we know that sometimes running a project, a patient safety program, is a way to galvanize support and engagement. I also know that the summary of the SAFE program is the college's highest download of anything that relates to quality improvement or patient safety. So there's clearly an appetite for people to learn about this. And you're running these courses in Ireland, but if there are units who are going, okay, we might have done this a few years ago, or we like the sound of this, how do they go about introducing this process? What are the steps for people to go, okay, I want to test this out in practice and try and develop this culture?
So what I've done is managed to take a course that we took 2 years to do in the first time. Now we do it in 6 months. So what it is really empowering people. So I said to the health service here who funded, I said, look, my view of the SAFE program, which is the main aim, we say, what is the main aim of the SAFE program? And when we got the funding, I said to the Health Foundation, oh, we're going to save lives, we're going to decrease harm. And I said, there's no way I could claim that, because at the same time, there was sepsis 6, there was other things going on, so who knows what worked. But I said, one thing I can tell you, I'm going to change the way people think, and I'm going to measure that. Because if I know that if people are thinking about safety, the other things are going to happen naturally. So I said to the health fund, to the funders here recently, that this is how I see the SAFE program. It is like immunization. Unfortunately, it is not like measles immunization. You have 3 doses, and then you find you don't have to have another dose. Or like smallpox, you have 1, and you never have to have it again. No, it's more like influenza, but actually it's more like COVID vaccine. So it only lasts a few months or a year. And you have to have re-immunizations every year in order to be safe. So this is what I said to the Health Foundation as well. I said the problem with the program was that it was only funded for 2 years, but I actually need a 10-year program in which what I'm doing is building up teams every year. And then what happens that every year the team comes back for re-inoculation. So every year a team will come back and gets only a 1-day course. And we did that in Ireland. So we tried that in May. We brought back teams. And there was one team I'm going to talk about. I'll shout them out. They're from Sligo area. And they had come on my very first SAFE program before COVID in 2017-18. And they came back 1 unit. And now in their region, there are 5 paediatric units. That 1 unit was brought back 5 units with them. They had started a regional SAFE huddle program from that very first one, and they came back for the re-inoculation. And that's what they did, because we updated the latest theories, because of course I've changed the way we think, the quicker way of doing it, because my whole idea is how can I take this very complex theory and get people to do it part of their day-to-day lives without thinking I'm doing safety now. So they're talking about it, it's what they do, it's hardwired in the system. And that's what the big thing in quality improvement. Quality improvement fails because they do projects. Once the project's over, they go back to the old way. So what we really want to try to do is say, this is the way we think, this is the way we do it, but you do need this re-inoculation. So to answer your question, Jonathan, what I would suggest to the college is to run a course, which you could probably charge for a little bit, once a year for teams to come on to be re-inoculated, to get the latest updates on patient theory, to talk about the experience, to learn from others and how we can do it. And that should be part of it, because patient safety is very difficult. in the environment, and particularly it's very difficult now in the NHS, under a lot of pressure from the workforce because they don't feel safe. And part of them not feeling safe is why they're on strikes. That's part of the deal. And therefore, they're not happier when they go back after they have to go back to work in these conditions. It's also because I think there's a lot of lip service as an NHS strategy, but application can't be done. And a lot of programs can't be done unless people are talking about it every day. And people are not talking about it every day. I would say that if I go into an organization, I see the slogans, and then I have to ask the CEO and the finance director, how much money are you spending on patient safety? How are you doing this? You'll see that they don't answer because they don't do it. They talk the slogans, they don't actually do it. What has to happen? Every member on the team, from the cleaner, who's not a cleaner, is an infection preventer, to the surgeon, who is preventing harm and surgical site infections while I do the operation. Can you see? That's how they've got to talk. So we've got to really transform things. And I think it starts at the microsystem level with support from leadership.
I wonder if there's also an aspect there around I think you've touched on this a little bit, around the difficulty of measuring what is a safe culture. And it's, in one sense, it's quite natural that people rely on slogans because it's easier to grasp on, sort of put the slogans in. You can say, so NHS England have got their guidance and toolkits of how to create a safe culture. And it's like, well, therefore you can just do that. But then there's no understanding of, okay, how do we know whether we are safe here today? And you mentioned the use of the Manchester framework, the MATSAV, and I remember years ago, there were conversations, okay, is this a model that we can use to keep tracking over time and answering that question? I'd be interested to know what your view is on how organizations should lean into this. And I know there are dangers of having a single measure, but what would the process to be to understand, are we safe? Have we a safe culture?
A safe culture is about what you feel, what you feel and think.
Okay.
So my first thing is that patient safety is a misnomer. And I've said this to the WHO and so on, is that we talk a lot about patient safety, but the most important thing is healthcare worker safety. Because if people feel safe, then they'll be able to be safe. So they've got to feel safe to be safe, okay? So if they're feeling unsafe, there's no way they can be safe. And COVID really showed us that. So I think the first thing we have to do is on that. The Manchester Patient Safety Scale is very useful for clinical teams to measure their own safety, and the only comparison is between themselves, how we were last time. And it doesn't matter if it's different people marking it. Let's say we did it in Natalie, in your unit. We did it today. And then in January, you get your new SD1s come in, and they do it again. They would give a higher score because things have changed over the 6 months. It doesn't have to be the same people saying, this is what I felt last time. It's just because, what is it like now after you've been here for 3 or 4 weeks? How do you feel? And people will say, well, I feel safer because this is what's happening than my last unit, which was somewhere else. But you're not comparing that last unit. The leaders in that unit are saying, gee, what's happened here is we've gone up a notch with these trainees. So we are doing something right. So the Manchester Patient Safety Scale is very good for clinical teams to measure themselves. If you want to measure between different organizations, that's a bit more complex because there's the ARC tunes, the context, and I don't think that's very useful. It's very good for politicians, but what's very useful is that when the patients feel safe, okay, and when the patients feel safe, where the mother says, people listen to my concerns. I didn't tell you some of the other stories on, but when I was at clinical director, on 4 occasions, I had to tell parents we watched their child die. We actually watched the child die. It was very traumatic for the parents, very traumatic for the staff members where this happened. And on these occasions, these were very good doctors, very good registrars, and excellent consultants. This is before the patient safety days. This was in 1999 to 2000. And I had a run of 4 incidents where there was tunnel vision, or they made the misdiagnosis, or they didn't intervene. But in most cases, they didn't listen to the mother. In all cases, in fact, in all cases, the mother said, I'm worried, and the child's clinical signs were fine. And they said, but the clinical signs are fine. I said, but the mother was the arbiter. So when mothers feel listened to, when the parents say, they listen to me, they treat me as part of the team, I feel that my views are held, are listened to. Can you see the difference? And that's what you'll hear from most things. So the measures are qualitative rather than quantitative. And I know people love quantitative measures, but culture is not a quantitative thing, it's a qualitative thing. So we've got to bring in qualitative measures, and that is listening to parents. It's going up the co-production nugget, where parents feel that I do things with you. You don't do them for me. You don't do them to me. I'm an equal part in the care of my child. The biggest harms we have are medication safety and infections. What do we do with a child who has got a chronic condition, make it cystic fibrosis, comes into hospital? What do we do? The first thing we do, we disempower the mother by saying, you can't give the drugs. A nurse is going to give the drugs. Why? Hospital policy, medical legal issues. Who is the safest person to give medications? The mother who does it every day at home, or the nurse? Can you see the difference? Doing it to or for to doing it with. Can you help me give the medications as you know best? Can you see the difference? I'm going to give your medication to the child now.
And having those quite complex reflection processes to go, okay, let's use different measures to understand what does good look like. And part of that may be that we are having the right person with empowered to be involved in safety, etc. I'm struck by the very first story you talked about, where you said we had this terrible incident, but this was a high performing system. And that language, we say, well, we are high performing. So how do we get that change of saying a measure of what high performing is that you are in a safe environment? So it's having that shift around that language. That it shouldn't be possible to claim you're high performing and have forced safety in an environment.
Well, look, I worked at Great Ormond Street for 12 years in patient safety. And when I started, I was fortunate that look, Great Ormond Street is called the Children's Hospital. It's very high performing. They said, we need to be high performing in safety. And that's why I looked at Cincinnati in particular, because Cincinnati had the same approach. They were very high performing clinically, but then they had a major serious event, and the chief executive said, what's going on here? We've got to be the best in safety as well. And then they made high performing in safety as one of the outcomes they wanted. So we wanted to do the same at Great Ormond Street. So we started measuring high performance in terms of safety, and we really did well over the time I was there, mainly because what we looked at is how can we make safety an everyday business? The leadership has to define what they really mean by high performing, and also the college needs to define what they see as high performing when they're doing their college visits. They must start to measure about safety incidents. They need to start talking to the staff. The medical schools should be doing the same when they place medical students and say, do you feel safe in these units? And if not, we need to talk to the units about that. I'll go back to one other story I have. I was clinical director, and then the trainees in obstetrics complained to the deanery that they weren't being supervised or they weren't being trained adequately. We had a number of maternal deaths, and we investigated normal root cause analysis, could find anything. But what was happening, I realized that what the trainees were saying to us, not that we weren't being trained, that we were feeling unsafe. And when I went to RHI and learned about patient safety, I realized what they were saying. They were saying we do not feel safe in the environment we are because the consultants are not in labor ward with us. So we have to make these difficult decisions. So back to your question, Jonathan. If you want to measure it, you've got to measure certain outcomes. So you have to measure the incidence of harm in our areas. I have a number of obstetrics teams on the SAFE program, and that's exactly what we teach them. How do you measure the harms that happen in your area, and how are we going to decrease it? And the most biggest one, harm in obstetrics, I think, is postpartum hemorrhages. How can we eliminate postpartum hemorrhage to as far as we can? Because that is often seen as a consequence, but if it's under 500 mils, it's not. So how do we define it? Any postpartum hemorrhage is an issue of concern. And how can we predict it? How can we predict who may have it? How can we do it? And I've been asking women, midwives, trainees, medical students, and consultants, do you feel if you're safe? And asking all of that, and all that qualitative stuff, plus the quantitative of harms, would then give me a good measure if that unit is safe. Can you see how complex it is? But I started addressing it from both qualitative and quantitative way, and including everyone, mothers and clinicians as well.
Absolutely. And one of the things that strikes me, Peter, many things that you said during this talk today, it all seems to come back in the very beginning to language and giving, like, arming people with the right language to approach these situations. So what you said there of trainees not having that language to say that I don't feel safe, just saying we need more training. Often, if you haven't given people the words to use, it's very difficult for them to participate.
Yeah, and I think one of the things we teach is that a unit must decide on its language that it can use to feel safe. Jonathan mentioned the hierarchies. Unfortunately, we have a hierarchy system where people feel that if they show any weakness, they will not get a reference. So they will never show their weakness to their consultant, really, because then they'll say, oh, not a good trainee, what they're going to do in my reference. So they always want to please. But if the consultant shows fallibility, if the leaders show fallibility, then the juniors or the trainees will show fallibility as well. An example I give you is I'm kind of dyslexic when I write scripts, and I used to I make mistakes. So when I had medical students in, I would say to them, look, I need you to check what I've written because I always make mistakes. So I'd always give my scripts to the medical students to check and to calculate what is serving two purposes. I was teaching them psychological safety without mentioning the word, because I showed my fallibility, and they were learning how to write scripts. so they were learning how to be safe prescribers at the same time. Can you see? So that was a situation which worked both ways. That approach is very important to do. But in terms of language, Natalie, a colleague of mine from the States said that we have to have words that people can use. So, for example, often the nurse will say, I thought this was wrong. Or the mother will say, I thought what they're doing is wrong. So basically, a word that you can use, or you can choose a word, is like if a doctor writes up a script or gives an instruction to a nurse, or the senior doctor to the more junior doctor, and the more junior person in the hierarchy feels that there's something wrong with it, they say, can I have clarity? Or is this what you mean? You can choose whatever word you want to have. Or let me make sure this is what you want. That signal says, let's start again. Let's redo the calculation. Let's think about it again in a non-judgmental way. So what it does, it breaks the hierarchy as soon as someone says the key word that the organization has decided, that you have to step back and say, maybe I've made a mistake because someone is questioning it. And usually what happens, the more junior person will say, I thought it was wrong. And the junior person may be a different profession, nurse to doctor, for example. I thought it was wrong, but he's the doctor or she's the doctor, so I couldn't really challenge. So we try to flatten it by giving them a word they say, which is non-judgmental. And that the cue from the doctors is as soon as someone says that, they say, okay, I've got to start again because there may be a mistake.
What's fascinating about this is that what you're talking about is the right practices to follow to create high-performing teams, high-performing systems. And something that struck me with all of these conversations around patient safety is that we tend to be talking about high performance and just asking the right questions, doing the right thing to enable people to do their jobs as best as they can do, that everyone working together. The theory and frameworks we have in safety are so useful to frame conversations like this on how we do things better. So if you're trying to tackle something like health inequalities, it's tempting to feel like a complexity is too much. But there's an argument of going, if you look about, let's take a patient safe or take a safety approach to this, there are solid frameworks for you to be, or sort of theoretical background and practice to go, this is a way for you to say, okay, because we are underperforming and doing badly for certain groups, this gives us a way forward to perform better. And it strikes me that that may be a key theme for all of these conversations. I wonder what you think about that.
Well, see, the thing about equity is that in the safety movement, it's only been starting to speak about it now. The fact that if you're from an ethnic minority or a different grouping, your outcomes are worse. So if you a baby who is, which is quite interesting, now they're suddenly discovering that APGARs don't work in babies who are of a different hue or different color. And I said, well, I knew that I came from South Africa, so I knew that straight away. And now they're suddenly discovering it's many years later in the UK that you've got to compensate when you're doing jaundice and when you're doing APGAR scores and so on, which are safety issues. So basically on inequality, if you come from a Black or Asian ethnic minority group or a refugee group or immigrant group, you're at higher risk of harm than the average white English person. And I think that equity applies to terms of safety. I use the same principles. Every day, the consultant should be saying, are we treating everyone equally? And not even equally. Are we providing more for those who need it? So if there is someone who is more deprived, how are we going the extra mile for that person? Have we really taken all the factors into account to ensure that person's safe, they could do things and so on, and not then say, oh, they didn't comply. So for example, if you have a medication you give to someone and it has to be kept in a refrigerator, do we ensure that that person has a refrigerator and can afford the refrigerator 24 hours a day with the electricity costs right now? Can you see those kind of things? Are we asking that kind of question? That's a medication safety question. So really every day, as talking about safety, you didn't ask me to talk about equity, but on equity, do we have a culture of equity? No, we don't. People talk about it, but do they really do something? And doing something is the consultant leader every day is saying to the clinical team on the huddle, the safety huddle, have we gone an extra mile? Is there anyone who needs extra? Have we taken all the factors into account that may affect this child? And that's not happening. And until they're doing it, there's no culture of equity in the NHS. There's just nice showpieces that they have. And you can see it. You can see what happens, because if you ask the trainees who are applying for jobs, we still discriminate. They still discriminate, okay? You ask the trainees or young child how they treat on the ward, there's still discrimination. So we've really got to pay equity at the same level and talk about equity every day. So quality, safety, and equity are as important as clinical outcome and clinical conditions. Yet, on ward rounds, they talk about clinical conditions, pathology, physiology, but they don't talk about quality, safety, and equity.
Just really to sort of to wrap things up a little bit, you've said some really, I think, brilliant sort of calls to action of where we need to start tackling this. So the role of the college, the role within education, postgraduate and undergraduate. For somebody who is listening to this podcast, obviously we're aiming this at the paediatricians, members of the RCPCH, individuals listening to this. Do you have a starting block for them? Do you have a call to action for them?
Yeah, well, when we did the handbook of patient safety, it was designed for people in the front line. And I'd really push it that every clinical team should have a copy. I'd argue that every trainee should be given a copy, not have to buy it themselves. The trust should be buying the handbook of patient safety. I'd say to the consultants who don't know much about patient safety because it wasn't part of their training, they've been around a long time, I'd say call on the college to give you opportunities to learn about patient safety. You don't have to become experts, but to learn about patient safety. So that's what I'd do. To all the clinical directors, make patient safety one of the issues you're going to do and make sure you know how to do it. So you don't have to know everything about it, but you have to be the enabler for your teams. So that's what they have to do. To the medical directors, the similar kind of story, that you have to be enablers, know how to measure it, know what to do. For the trainees, demand that patient safety is part of your training. Now, I would say to the college, the fact that we're sitting here today shows that the college has moved a very long way in the last 15 years. And this gives me a lot of pleasure because I've been working with the college for a long time. And it's great to see that we have you both in post. So that's a very important thing, is that the college now is taking patient safety seriously. And that's a very good thing, because in order for us to make a difference, the professional body has to make this a priority. When the professional body makes it a priority, the members of the professional body will start making it a priority. When the members of the professional body, the consultants and the trainees start making it a priority, then the employers will start making it a priority because they start to talk about it and so on. So I think that the key thing is come on one of the courses the college offers, explore the website, read the books, go on courses. But the most important thing is every day start talking about safety. It's so easy to start the next day, tomorrow morning, after you've heard the podcast, to say to people on the team, on the ward round, what kind of harm do we have here? And are we safe right now? And will we be safe tomorrow? What do we have to do? It's no use waving shrouds and saying, oh, the government's got to give us more money and so on, because every day you can decrease medication harm. And I'm going to kind of end on this story, is that we are doctors who prescribe. That's one of the things that defines us. Things that make us a doctor is that we can prescribe medications and we can sign death certificates and birth certificates. So we can bring people to life, we can bring them to death, we can give medications. Medication harm is the number one harm worldwide. Number one harm. It's either poor prescribing, poor administration, and poor reconciliation of medications. Overprescribing, underprescribing, polypharmacy, you name it. All of those are what doctors do in a culture of safety, which we're talking about. The consultant will say to the registrar and the house officers, will say, on this ward, our scripts are 100% correct. And every week, I'm going to look at a random sample of scripts with our pharmacist, and we're going to make sure that we get 100% prescribing, correct prescribing on this ward. No energy required. No extra work. No extra funding. So what's going to happen? Firstly, they're going to measure prescribing errors. Secondly, they're going to decrease prescribing errors. Thirdly, they're going to engender a culture of safety around prescribing, which those young doctors will have all the time throughout their careers. They're also going to decrease adverse events from prescribing errors by doing that, because they're starting to talk about it. That's something every consultant who does a ward round every day can do without any effort, saying prescribing is of importance to me. Because if you go to the pharmacist, they will say they are continually correcting wrong scripts. Yet, that is what we permit. And a good saying from a friend of mine, Pat O'Connor, says, what we permit, we promote. So if a consultant permits poor prescribing on his or her ward or clinical area, in the outpatients on the ward, and they're prescribing errors, if they permit that, they're promoting poor prescribing. So that's what they can do. That's about the culture of safe prescribing, which we do not have. So that's the easiest way to start. Very complex, but that's where I would start. I'd say, let's just look at prescribing. Let's get that right. 40% of all harm is due to poor medication. Can you see where I'd go? So that's where, just go back to a college program. That's the problem, the medication safety program the college has. That's something that should really be extended, because it should be high up front again. You know, a lot of work was done a few years ago, and that's really where we should be looking at. Then after that, we come with infections, etc., etc.
So thank you, Peter, for taking the time to share all your knowledge and experience with us. Obviously, so much progress has been made over your career in bringing patient safety more to the foreground, but there's still so much work to do to make safety a priority in healthcare. As you described, we as individuals need to be supported to change the way we think about safety, and then the safety culture can grow from that, and ultimately then the children and young people we care for will be safer. So for more information about developing a culture of safety, the SAFE project, and about paediatric patient safety in general, please visit the RCPCH Patient Safety Portal. This is a brand new online resource full of learning, resources, safety alerts and more. You can find links for this and for the research and the projects that we've discussed in this episode in the notes for the podcast. Thank you for listening.